Welcome everyone. Lovely to have you with us. And we are doing the last in the seminar series around the evidence in social prescribing. And we've got two presentations today. And before we start our presentations, I'm going to hand over to Anthea, who's Head of Evidence at NAS, because you've got a couple of things you wanted to say, haven't you, Anthea?
Yeah, hi, thanks everyone. Thanks very much for joining today. I'm sure it's going to be a really, really fascinating session. I'm Anthea Terry. I'm the Head of Evidence and Evaluation at NASP. I've also got a colleague, Olivia, on the call. Marie and Sonia have kindly let me have a couple of minutes at the start of the webinar just to share some news with you all about the International Evidence Collaborative moving forward. So as you might know, the IEC was co-developed by NASP and a group of academic partners in 2021. NASP has continued to fund the IEC, and it's been really brilliantly co-led by Marie and Helen Chatterjee with support from Sonia via the Social Prescribing Network. And I'd like to say a really huge thank you to Marie and Helen and Sonia, as well as our previous and ongoing academic partners for all of their work in developing this group and curating such an interesting programme of webinars over time. It's just a real privilege to be able to hear from so many voices in the social prescribing research community. After today's webinar, the management of the IEC is going to be moving back in-house to NASP. So you might receive some communications from a different email address. I'm not entirely sure if it will look different or not. We're going to send out a really short survey to ask for your views and feedback, both on the webinars, but more generally about the network. And we're going to use that input to plan a programme of engagement that we hope to be able to announce very early in 2024. So please do keep an eye out for that email or get in touch with us via our email address, which I'll pop into the chat just now. And just to finish off really with another huge thank you again to Marie, Helen, Sonia, all the other people who've worked so hard to really grow and make this such a rich and interesting community. And I'll hand back over to Marie.
Thanks, Anthea. Wasn't expecting that, but you're very welcome. It's been really interesting bringing the research community together. So I look forward to hearing what people want going forwards. Let me introduce our first speakers. So we've got Dr. Abby Wood, and whilst I do that, I'm just going to let another person in. So Dr. Abby Wood, and we've got Sarah McMullen, and they are at UCL. So they're in the Department of Primary Care and Population Health. And the reason I'm really interested in this presentation, because it's looking at improving support services for family carers from the Pakistani ethnic group. And actually we talk a lot in social prescribing about how we can support inequalities, improve access, be culturally relevant. And this is a study that really speaks to all of that. So if I can hand over to Abby and Sarah, welcome.
Thank you. I'm just going to share my slides with you. Bear with me. I'm hoping you can see that.
Yeah, that's brilliant. Thank you.
Great. Okay, so yeah, thank you for having us here today. So me and Sarah are going to talk to you about our project that's looking at how support services for Pakistani family carers can be improved through social prescribing. So the project is funded through the National Institute for Health and Care Research, and we're working with a team of co-investigators and collaborators across Queen Mary University of London, King's College London, Sheffield Hallam University, and also other members of the team that are located at UCL as well. We're very proud as well to be working with our community partner, Waltham Forest Women's Network, and we also have a really great patient and public and involvement and engagement group who have lived experience and have been able to draw upon their cultural background and provide input from that side of things. So I just wanted to start by giving you a little bit of background. So there are more than 600,000 minority ethnic carers in England and Wales. understanding how Pakistani family carers can best be supported in their role as a carer is really important, because there's a very high prevalence of informal carers from the Pakistani ethnic group, but they're also less likely to engage in support from outside of their informal or family networks. And evidence shows that experiences of minority ethnic carers can be very different and more challenging than those of their white British counterparts. And while caring responsibilities have a significant impact on the physical and mental health of carers across all groups, higher levels of social isolation exist among Pakistani carers. Social prescribing programs can help to support carers, and research shows that early intervention through social prescribing could actually reduce the risk of carer depression by over 20%. But unfortunately, as many of you may know, minority ethnic groups are often not included in or offered social prescribing. And the role of social prescribing in supporting the Pakistani group is underexplored, particularly in relation to the cultural and religious challenges around access to support. So the aim of our study was to explore how Pakistani family carers can best be supported in their role as a carer, and how culturally sensitive social prescribing services can be refined and developed to improve carer health and well-being. So we conducted interviews with Pakistani family carers, but we also recognised that it was important to include the voices and perspectives of stakeholders, especially around the primary care and social prescribing landscape. So we interviewed healthcare professionals, social prescribing link workers, and also representatives from voluntary and community sector providers of social prescribing. Our analysis is ongoing, so the findings that we're going to present in a moment are preliminary at this stage. I think someone just needs to turn their microphone. Okay, great, thank you. We were fortunate enough that Sarah, who you'll hear from in a moment, was able to conduct interviews for the carers in both English and Urdu. And you'll see from this flyer here that we had our flyer translated into Urdu. So we worked with one of our PPI partners, our patient and public involvement partners, to translate the recruitment flyer. And we feel this is a real strength of the study, as well as being able to offer those interviews in Urdu as well, because we were able to reach a lot of people that are typically underrepresented in research. So I'm just going to hand over to Sarah now to present some of the early findings to you.
Yeah, thanks for that, Abby. So we're currently in the initial phases of analyzing the data, and we wanted to walk through 3 emerging themes that are evident within the carer and stakeholder interviews, and the first one being carer identity and duty of care. So overall, there was a variation in Pakistani carers self-identifying as a carer. Some carers accepted their role as a carer and made their GP aware of this, and also received carer allowance. Others were unaware of making their GP aware of their carer status, and didn't really understand the importance or potential benefits of notifying their GP. Carers also rarely visited the GP for their own needs, and there was an overall lack of prioritizing their own health and well-being needs. Majority of the carers that we saw, majority of the carers that we spoke with saw their caring role as their duty towards the person that they cared for, and taking care of their loved one was often not a choice, but a responsibility they were born into. Many carers highlighted that in Islam and Pakistani culture, taking care of family members who are in need, sick or elderly is the norm. And the first quote here on the slide is from a 43-year-old female carer who explains that there are cultural norms around the identification of carers. And she states that what needs to be recognized is that there's a lot of people that don't refer to themselves as carers, and I think there's a lot of stigma attached to the people because it's seen as a duty. It's not seen as a caring role. It's a part of your role as a daughter-in-law, son-in-law, or daughter. The interviews also highlighted that family dynamics played an important part in the informal support structure for Pakistani family carers. Some participants highlighted that caring responsibilities were often shared by family members within the household, and it was noted that the family member registered to be the primary caregiver at the GP practice might not always be the one primarily responsible for caregiving duties, leading to potential inaccuracies in carer GP records. Carers also highlighted that many things are taken into consideration, including what friends and family might think of the support coming from outside the home. And support from outside the home was often minimal due to stigma and negative connotations attached to the quality of care provided. Also, there was a perception surrounding what others will think, and getting any type of support from outside the family, including benefits such as carer's allowance, was often a decision made by the family, not just by the carer and the person being cared for. And the second quote on the slide is from a 63-year-old female carer who describes how her family relationships are broken down due to her caring role, and how her brothers had an expectation from her to take care of their mother. Next slide. The second emerging theme within the data was awareness and attitudes towards social prescribing. In the interviews, we found that none of the carers who took part in the project had received a referral for social prescribing. Most carers had either never heard of it or had very little awareness of what social prescribing is, but demonstrated a need for carer-specific support. Overall, once we explained what social prescribing is, carers were positive about what these services could offer. Many carers suggested that they would go to the GP and ask about social prescribing and try and get referrals for these services after the interviews. A lot of the carers wanted to do more physical activities, and women in particular highlighted that they needed someone outside the family to talk to, such as other carers, but this needed to be in a confidential setting and without them feeling judged. The first quote here on the slide is from a 38-year-old male carer who is keen on receiving support through social prescribing services. And he states that in terms of social prescribing, to be honest, that's the first I've ever heard of it. I will definitely have a little look and raise it up with my GP practice. Maybe the information you mentioned about getting referrals to social clubs would be fantastic. Stigma around receiving support for mental health was also highlighted within the interviews, and this was linked to some negative attitudes around the concept of social prescribing. Like the second participant quoted here is a 41-year-old Urdu-speaking male, and he explains the challenges he has faced within his family, saying, "We need something for anxiety to build confidence within us. If I tell my relatives this is something we can take part in and it will help us, they will tell me it is for white people, it's not for us, and they will laugh at me as well." Next slide. I will now talk through some stakeholder perspectives on increasing cultural awareness across social prescribing pathways. So both carers and stakeholders identified the need for cultural awareness. Stakeholders in particular stated the importance of cultural awareness among healthcare professionals and social prescribers. A need for more training was highlighted, as being culturally aware doesn't necessarily mean you have to be someone from the same culture or ethnic background. As such, regardless of ethnic background, it was felt important to make an effort to understand specific patient groups, and some stakeholders made an effort to educate themselves about taking a culturally sensitive approach in supporting patients. It is also important to understand that everyone is different, and there is also diversity within and across Pakistani communities. The first quote on the slide here is from a white British occupational therapist, and he states that I've made a conscious effort to network shamelessly. Also, I think knowing and learning about the patient group here. I don't come from a Pakistani background. Just in terms of being culturally sensitive, I wanted that information. I can best support my patients in terms of social prescribing pathways. Stakeholders also highlighted that identifying more individuals as being family carers in general would help them with being able to do a proactive social prescribing, where a targeted plan can be developed alongside the needs of the carer, taking on a more holistic approach towards health inequalities of that person. However, one of the main challenges around proactive social prescribing was the identification of carers. And the second quote here is from a British Pakistani link worker who states that if people were identified as carers, we could run a list and target, do social prescribing with them. But if they're not identified as carers, that's the first step we need to take. Next slide.
Thanks, Sarah. So I'm just going to summarise some of those findings for you. So our data show that the ethnicity of healthcare professionals or social prescribers can be important, but that improving cultural awareness among these groups is more important for developing those tailored support plans. And one way of assisting with this may be through proactive social prescribing. So proactive social prescribing was recently introduced as an additional requirement for primary care networks, meaning that they must work with a population experiencing health inequalities to proactively offer social prescribing interventions. We know that there's no one size fits all model of social prescribing. We know that individual experiences of social prescribing differs, as well as there being variations across different areas. But our research suggests that healthcare professionals and social prescribers do want to be more culturally aware, and they want to be able to offer support that is culturally competent. A key challenge of being able to offer proactive social prescribing is the social identification of carers, such as through GP practices. And our findings suggest that this is an issue that's specific to not just Pakistani carers, but it is an issue that relates to them. Beyond this, there are also challenges to overcome at the individual carer level, which can be due to cultural norms around duty of care and complications surrounding family dynamics. The latter is quite a big challenge to overcome, but one step towards improving things might be to have more effective strategies in place within healthcare systems that can help with identifying more patients that are also carers, and perhaps having joint conversations between the carer, the decision maker in the family, and GPs. In addition, there's a need to increase the awareness of social prescribing among Pakistani carers. This may be the case for other minority ethnic carers too. But what we did find interestingly was that despite a lack of overall awareness of social prescribing among nearly all of the carers that we interviewed, overall they did display a very positive attitude towards what social prescribing was and what it could offer. And this is really important because there were lots of reports among carers around unmet health and wellbeing needs, as well as a perceived lack of culturally competent support provision available, and challenges around how someone like a GP might be able to actually help a carer. One thing that we'd like to reflect on in relation to raising more awareness is that we found, just as Sarah mentioned previously, just by talking to people about social prescribing through these research interviews, we've actually been able to increase some of that awareness around social prescribing. And as a result, several carers did say that they would follow up by going to their GP to ask about it. So I think the case is really that if the support does exist, it's possible to increase awareness of social prescribing, but we just need to find a way to reach people to tell them about it. Carers told us that advertising social prescribing programs and opportunities in English as well as Urdu would really help, as well as targeting places that they go to regularly, such as mosques, local shops and libraries. So just to finish up, we want to tell you what some of our next plans are. So in the immediate future, we'll be sharing our findings through a publication in an academic journal that we hope will be available early next year. We also have some face-to-face and online dissemination activities planned that are designed to facilitate knowledge transfer and mobilisation. In the longer term, we also have a lot of exciting work coming up to build on the findings from this study. So I've secured funding through the NIHR for the next 2.5 years. The first part of this is to undertake some additional interviews with carers to look at a subset of the original study population, which is carers of dementia from a South Asian background. Following this, I'll be focusing on bringing all of the learning together from the interviews conducted to date to undertake a project that will ultimately co-produce a set of recommendations and guidelines needed for delivery of social prescribing that's inclusive and accessible for carers from minority ethnic backgrounds. It's not on this slide, but Sarah is also hoping to secure some additional NIHR funding to conduct a qualitative study that's looking at mental health and wellbeing needs of family carers of people with dementia from a South Asian background. So lots of new research coming up. Okay, thank you very much. Does anyone have any questions?
Thanks very much, Abby and Sarah. That was really interesting. I was very interested about the kind of the family dynamic I think that's different to what we see in Caucasian populations. There's a similarity that I hear a lot of people don't see that caring is something that they should be getting paid benefits for, but that's just their role because they're in the family. And I hear that a lot across social prescribing schemes, regardless of ethnicity. But the family dynamics of being expected to be the carer, I think, is certainly sounds very different. It's not something I hear so much. And I agree with you. I think workforce needs to have a lot more training. There was some work done in can share the report. Actually, it was in West Yorkshire ICB, and they've done a lot of personalised care training, and one of the most popular courses was around ethnic and cultural kind of competence and understanding how to be more appropriate and sensitive to needs. So that's interesting, and I'll connect with you on a different study because I'm part of a massive NIHR study designing social prescribing for people with dementia, and I notice you're going to do that follow-up work, so I'd like to connect with you about that because it would be great to understand what you find. But if anyone's got a question, feel free to stick your hand up because we're a small group today, but this is being recorded. It'll go out to everybody that's on the database as well. Anthea.
Yeah, thank you. It's really, really interesting work. I was just I was wondering if you had any more reflections on, are there any sort of specific challenges around social prescribing compared to other sort of health treatment pathways? Like, are there things that make it easier or harder in terms of addressing different needs? I'd just be really fascinated to hear anything you might reflect on about that.
I'll start off and then I'll see if Sarah's got anything to add. I think one thing is having something that's specific to carers. I don't know whether others have found this as well, but that's one thing, of having something that actually relates specifically to carers. So, you know, people may talk about other things that they know about or they've been told about through word of mouth, but they've talked about them more in terms of them being generic support rather than something that might help them as a carer. But the other thing is something that's relatable in terms of the cultural sensitivity, or whether services are thinking about gendered activities and how appropriate it might be for male and females to mix when that's appropriate. And it's not always the case that everything has to be segregated, but we found very much that there are some instances where that is necessary, and then there are other circumstances where it wouldn't matter so much. So I think it's that, but it's also just that whole lack of awareness. So if people aren't going to their GP, they're not finding out about social prescribing, they're not being referred. And this is a group that typically weren't being referred to anything at all. So I don't know whether you've got anything to add, Sarah.
No, I think you mentioned everything. The only other thing that I would probably mention is something that was highlighted in not just like the Urdu interviews, but also the English ones, was language support as well. So people really pressed on that and said that, you know, how can they expect us to go to a group, even if they were offered anything locally, when there's no provision for language or people don't speak the same language. So that was really difficult for people.
That's really, yeah, they're quite big problems, aren't they? They're not simple fixes to a bit of a tweak here or a bit of a tweak there in some cases. But if you had a magic wand and you could make 2 changes to the way social prescribing is provided and rolled out at the moment, perhaps one each, what would be your kind of priority change? Abby, come to you first.
I was going to ask Sarah. One priority change to social prescribing, or the way that people access it?
The way it's provided for this particular group.
I mean, the main, I think the major one is kind of what we've just said about having that accessibility around language, gender, you know, having that cultural insight into communities and understanding that people are different. So it's not a one size fits all. It's very much, you know, tailoring. And I think just tailoring to minority ethnic groups as a whole might not be the answer, because there are nuances. You know, they're not a homogenous group. So I think it's having that awareness that there do need some slight differences, and yeah, actually thinking about what might appeal to people.
Yeah, thank you. What about you, Sarah?
I don't know if this is social prescribing in general, or I would say it's more general, not just social prescribing, but I would say the identification of carers, because that's the project we're looking at, and that's what we're looking at, is that carers are not getting the support that they need. So having probably better avenues within GP practices that allow carers to record themselves as a carer or register as a carer, but also receive the support that they, and that's a big one, receive the support that they need. So perhaps if even simple things like if the patient has gone with their carer to the GP practice, if the GP can just mention to the carer, oh, have you registered? Have you recorded? Have you go to the reception? Let us know. You're their carer. Just having that conversation. And I think like family dynamics again play a really, really important part in that, because even just within that conversation, that carer might realize that, yeah, it's not just a family thing. I need to tell I need to tell the GP practice about it, and I need to make them aware that I'm a carer. So I think it kind of starts there, and then it'll hopefully trickle down, and with proactive social as well. So yeah.
Thank you, because that's like making every contact count, isn't it? That kind of idea of we've got this opportunity, so let's try and use it. So, Shema, do you want to ask your question?
Thank you. It was really interesting presentation. Thank you. My question is to Abby. In some ways, I wasn't surprised that your sample hadn't heard of social prescribing, and it was really encouraging that they, having heard about it, they were keen to then go and explore this opportunity. But what I would like to know a bit more about is what you said at the beginning, which is that social prescribing is generally not being offered to minority ethnic communities. And if you can expand a bit more on why you think that might be the case.
I think it links to what Sarah has just mentioned in her last response, that it's about accessing people. So one of the main routes to social prescribing is through a referral from your GP, and people aren't going to their GP for their own health and well-being needs. They may be going to the GP with the person they're caring for, but they are very much not prioritizing their own needs, and that's not just Pakistani carers. I think that's carers across the board, regardless of ethnicity. But when you factor in additional barriers that may be there around accessing support for mental health, there are a lot of issues around stigma and mental health amongst South Asian communities. It's something that our carers spoke about in the interviews. It can be a very private thing that people don't want to discuss with their families, but they want to be able to talk to other people who are relatable and in that situation themselves, so other carers. But I think that stigma and those kind of pressures to just sort of to look after someone, that being your duty, that being your role, your responsibility within the family, I think that acts as a barrier in itself to actually seeking help, because people didn't understand what a GP could offer them. They say, I'm a carer, I'm not sick, I'm not going with an illness or an ailment, I don't think I need medication, what can they help me with? So they very much associated going to see the GP as being ill, and not really understanding necessarily that their needs are being unmet, and that a GP might be able to help. So it's that kind of first port of call, basically. I think, I'm not saying that is the only way we can try and resolve this or improve things, but I think it's a major one. I think it's a big sticking point at the very beginning of the whole process.
That's a great question, Shema, and thank you, Abby. I think it's like a multi-tonged approach, isn't it? You need, there's a lot of community, like matrons and nurses, that will be going out to visit families as well, who will be meeting families and meeting the carers as well, and the families, and they have an opportunity, and the GPs have an opportunity, and the community leaders have an opportunity. So it's like kind of something that NHS England could get behind and look at how to create a campaign on, or maybe it's something NASPA are interested in. And lots of food for thought there. Thank you very much, Abby and Sarah.
Thank you.
We're going to move on to the next presentation, and we've got Catherine with us, Catherine Aber, and you are Research Associate Public Health Policy and Systems at the University of Liverpool. And Shema can't make it today, unfortunately, so Catherine's got the responsibility of the whole presentation. But you're going to be talking to us about social prescribing practices across the Northwest Coast region, identifying essential elements and key challenges. So, you know, this is going to be really interesting. So, Catherine, if I can hand over to you, you'd like to share your slides?
Okay. Can everyone see that?
Yeah, brilliant. Thank you.
Okay. So this presentation I'm doing, it's summary of a paper that I wrote. Well, a group of us wrote. I'm the middle author, but we all chipped in quite a lot, which was using two different sets of data that we had, sets of information that we had, that we were doing primarily for other reasons, to look at what people in the Northwest Coast area, because we work for Northwest Coast, and before that Clark Northwest Coast, what they saw as the essential elements that they needed for a social prescribing programme to be successful, and what were the challenges that they were experiencing that would influence whether they would be able to have a successful social prescribing programme. So we use a really, really broad definition of social prescribing as any activity that supports people to access non-medical resources to improve their well-being and health. So that was whether or not there was a link worker, whether or not it was assessment, whatever setting it was in. So we used a really, really broad definition. So our main research questions, as I've already touched on, were what elements are viewed to the essential to the accessible social prescribing challenges, and what are the challenges involved in delivering a service that is effective. So the two kind of research methods or data sources that we use. We had a learning exchange workshop, which was for people who have been involved in implementing and evaluating social prescribing services, whether or not they were badged as social prescribing, within projects that had been supported by Clark Northwest Coast. So the primary objective of this was so that the participants could share learning and improve their own practice, but we also use it for this research. And a web-based survey that we sent to our Northwest Coast members, public advisors, and other people that had registered to attend a large event that we were planning, that we planned for April 2020, that obviously didn't actually happen, but we had the list of people who were interested in attending, so we sent them to them. And that was primarily to inform our upcoming research programme for ARC in social prescribing. And so the workshop, we had it in February 2020. It was face-to-face, so it's good timing. It was attended by 8 health and care professionals and 4 Clark or ARC public advisors, representing 8 services or projects with a really wide range of target groups and operational models. So some was just signposting, some was link workers, some were like joint resource hubs where you had the link workers in the same location as the resources that they were linking people to. And so the main topics of discussion in the workshop were: what did you find important in achieving the aims of what you wanted to do with this service? What barriers and facilitators did you encounter? And how did you do the evaluation and any challenges involved? And that was because as ARC, the evaluation is the kind of thing we do. And then we did the web-based survey, which followed the workshop, because we some of the questions were informed by the workshop. And we covered really kind of what people were doing, so the target group, referral pathway, funding, public involvement, how they did the evaluation. Also asked them about challenges to delivery and evaluation. So we got that little bit of extra information. And we got 49 responses covering 50 social prescribing services, again with a really wide range of aims, setting target groups and operational models. So the overall findings, so what I'll do, because it's a short presentation, I'll show you the model that we came up with at the end, or the sort of diagram as a start. So what we found, we thought there were 3 core elements. There might be other ways of thinking about this and picturing it, but the way we presented it is 3 core elements that participants identified as ways that things that their social prescribing programme had to have in order to be an effective social prescribing programme. So you need to do this. And then internal influences, which were influences in whether you could actually, have the core elements, support the core elements. So that was like around capacity in the system and evaluation. And then the external support was around stakeholder support and funding. So I'll go through those one by one, and I'll just keep flashing the diagram up in between. I don't know whether that was a good idea, but just so you don't forget. So core element 1 was a personalised approach. That was the title of the kind of label we gave to it. So this was something that came out of the workshop originally, and it had 2 elements. So one was the mapping of local activities and resources, which people identified as quite time consuming unless you had somebody else doing it. So that was to make sure that you knew what was available, so that when you'd work with people as individuals and giving them a really detailed individual assessment, motivating them in a way that was appropriate to them, and you could then link them into something that was most suitable for them. And in the survey, we found that 42% of the people responding to the survey identified a challenge within that in being able to motivate people to engage in the social prescribing or in the wellbeing activities from the social prescribing. So that was the challenge that was identified through the survey that relates to that, just to show you again. So the core element number 2 was whole systems working, and could also be called collaborative working. So workshops attendees noted that there was a need to build long-standing relationships with people in local services. So that was to develop a 2-way communication and partnership, which would enable you to sort of facilitate sort of joint service development delivery. Because if you haven't got these referral pathways or a strong community base of services to refer into, you're not going to be successful. Something on the survey, we found that 42% found getting the service up and running a challenge. So it doesn't quite exactly map onto this, but thought it does in a way, because this is really building a social prescribing service, actually the basis of it. And then the core element number 3 was public involvement. So the people attending the workshop viewed service user and local community involvement, depending on the type of what the programme did, as really essential. And they also and all of them did it, but that was because they were Clark projects, so they had to. So all of them had quite a lot of community involvement. And they also recognise the value of persons with lived experience helping to engage others in local services and support, and more involvement in the public developing local support activities, so the sort of things that social prescribers could link people into. So in the survey, 66% reported that they actually had service user public involvement or public involvement, including 38% who would use them for co-creation of the service. So it's not everyone, but it was quite a good high proportion. And then we've got the internal influences. So sorry if it sounds like a list, but I haven't had so much time to put this together. So that within the workshop, the attendees identified that they really needed the capacity, and there was sometimes was short on capacity in terms of skills development and training. So we needed the link workers to have the skills and the time and the funding to develop those skills. And that sometimes it just wasn't the capacity in terms of link worker time or volunteers. And also about the wider system. So if there wasn't the capacity within often voluntary sector organisations in the community, then there was no one to link to. So it was all really one system. So within the survey, it was identified as a challenge, but not as much as some other issues. Although, well, I think everything's linked. So 20% reported challenges relating to developing skills and capacity in the local activities, and 18% reported challenges relating to developing skills and capacity for link workers within. And evaluation. So evaluation was also viewed essential, not just for continuous development, but also for demonstrating effectiveness to funders and therefore being continued to be funding. There were various challenges reported, which is, if I've got time, I'll go through. In the survey, 69% had evaluated the service, although I would say actually a lot were fairly recently set up. So if we'd done it later, we might have had a higher proportion. And they also reported quite a few challenges to doing their evaluation. So within the workshop, the identified challenges related to deciding what measure or data to collect. So there were probably, with the validated tools, such as WebWebs and all sorts of other things, they often they felt they didn't capture nuanced change, or they were too clinical, and it was more of a wellbeing change they were expecting. The most common wellbeing tool, WebWebs, was sometimes inappropriate. It might be too long. There were some questions that were culturally inappropriate or inappropriate for people with certain illnesses, perhaps. But a bespoke tool wasn't validated, and therefore how much would people, how much could they trust it, and would other people trust it? And then it was about collecting the data. So how might the worry about how questioning people might affect the interaction that they're having and the way getting them engaged and motivated. And then there were problems in actually capturing and accessing the data they needed. So technical and bureaucratic challenges to sharing data across different agencies collecting different data, and therefore how could you interpret these different data, and missing data, people just not collecting data. And then it was something about demonstrating relevant outcomes from that. So have you asked the right questions? Are different outcomes valued by different stakeholders, and therefore what is important to measure? And the problem with capturing long-term outcomes, because some outcomes are expected to not happen straight away, and yet you might need to report straight away, within a few months to the funders, and the ever-present problems of resources, of time and money. And then, so we asked similar questions to survey respondents, and the biggest challenge seemed to be deciding on what outcomes or data to collect, followed by the actually collecting it or accessing it, finding time, and then kind of things like knowing what to do with the data, how to analyse it, satisfying funders' requirement, interpreting findings, and making changes based on the findings. So obviously that was an important one. And then external influence is sort of nearly done. The first one was stakeholder support, which we didn't capture in the survey, but in the workshop it was identified as really important to have support from local leaders in the NHS, perhaps local council, voluntary sector, especially commissioners, especially people with the money, because that would be essential to the long-term sustainability of your service and like embedding it properly. And funding was a big thing. So obviously you need adequate funding to ensure adequate capacity for your training, for your staff, but also for reliable funding so that you can plan, and so that services know that they expect you to be there so they can refer to you, and that there's also that capacity within the community services for the same reason, so that you've got someone to refer to, so that you have faith that they will be there. But in the survey, we found that most services had only accessed short-term funding 2 years or less, and that 62% identified securing adequate and sustainable funding as a major challenge. So it seemed like this is the challenge that challenges everything else. And this was done at the very start of COVID. So it could have changed, and it could have got worse, actually. So the main implications that we picked out were that it tends to confirm the findings of a lot of other studying guidance in the need to involve service users and members of the local community, the need to have a really individual personalised approach, the need to be integrated within a wider system so that you're actually supporting the activities that you're referring to, and for appropriate evaluation. And we also, it highlighted the need that probably everyone already knows for stakeholder engagement and stable funding, and indicates, I think, probably a research need for how best to evaluate services, because that seems to be quite like a sort of knowledge and skills gap at the moment about, knowing how to do it. So that's that. I hope I didn't overshoot my time.
No, thank you very much, Catherine. That's perfect timing. If you are able to stop sharing your slides,
of course,
which is the same box at the bottom. I think that's really interesting findings, looking at a region, first of all, but also I think what you found also marries with the evaluation scoping review that we did with NASP very recently, and those challenges of what do we measure, because there's lots of things that you could measure, and which one do we pick? I think it is very difficult, and the resources to actually then go and get that data and know how to get that data, I think they are fundamental now to creating, a solid evidence base. So I think you've highlighted some really interesting stuff. I wonder if anyone's got a question they want to ask. They want to put their camera on, put their hand up, ask any questions. Just give people a moment to think. When you said the west coastal regions, Catherine, where did you cover geography wise?
Northwest Coast, so it's Merseyside, Cheshire, Lancashire, and South Cumbria.
Right, so that goes up quite far then, doesn't it?
Yeah, it does.
And as well as those being coastal, are they also some of them rural areas? There's a mixture.
Yeah, it's a mixture. So we've got obviously like Liverpool, where I'm based, which is right at the south, but it's where a lot of the population are. And then further north, we've got some really, really rural areas and some coastal areas. We've got Blackpool, which is like a big coastal, very deprived area. You've got some very leafy, nice areas of Cheshire as well. So it's very, very varied area. And I think we found that I'm not sure, we weren't really able to do a sort of a statistical analysis of difference between areas, but it looks as though the issues were the same everywhere, and we did definitely identify that the core, what people identified as the core needs of their program was like completely independent of the model that they used. So whether it was a hub model, whether it was just signposting, it needed the same elements and target group. So any program that is doing this kind of well-being linking kind of work, they tended to report needing the same core elements.
And that's really useful to know, isn't it? That that irrespective of the wider, I suppose, external environment and influences, that there are absolutely core elements. Because I think understanding that helps you to really sort of bake that into the models that people are using.
Yeah.
And I think some of the stuff that you've highlighted even links with the work we did in 2016 on essential elements and put in our first report. You know, so yeah, I think that's really useful. Shivani, do you want to ask your question?
Yeah, can you hear me?
Yeah.
Yes, we can.
I'm
yeah.
sorry, I can't put my camera on, but
It's okay.
so I'm part of the evidence and evaluation team at NAS, and I've been trying to do mapping those link workers. So I just wanted to have your thoughts on best ways to map those people, and how we can overcome those challenges when we are mapping link workers.
Okay. So what kind of area are you looking to map? Is it a very, very local area, or is it a large area?
It's large.
Okay, that's going to be a real big challenge.
Yeah.
And we didn't claim to be able to map the link working with this survey. This sort of survey, we said it went into the wild. And we don't exactly know. We didn't have any control over who got it and who replied. I think you'll find it's very, very complex. So even within Liverpool, I was involved in another project to map what was available within Liverpool. And you'll start with the GP services, and even some are employed by GPs, some are voluntary agencies, some are even commercial agencies. But then there are so many other projects, I think, unless there's something locally where, like for instance in Liverpool, there's a link workers group, a sort of support group, an information exchange group. So a lot of people, most link workers are actually in this group, and we could go to this group and link it. But otherwise, I think you're going to need to do some sort of snowballing, I think, because there's so many things happening in secondary care as well. And it won't necessarily be somebody in the hospital who knows all these things, because one might be attached to a cancer service, one to a respiratory service. So I'd say it's really, really complicated, and to do it for a big area might not even be possible, except in the most kind of basic sort of rough idea of the kind of range that you've got might be worth doing.
Thank you, Catherine. That's quite a tricky question, I think, but there's quite a few, Shivani, there's quite a few people in the chat also saying we've been trying to do this, and you know, the people that are doing the national evaluation are also mapping this, and I think it's always been an organic thing that you've had to do. And I think you're right, Catherine, there's more and more developing in secondary care. We talk about GP practices a lot, but I've got a couple of projects in secondary care at the moment and social prescribing, and they come and go in different places. So
and not all of them are called social prescribing.
No.
And some are completely voluntary and completely outside the health service, and some are local authority, and it's really, you couldn't do it comprehensively. You couldn't map everything. By the time you'd finished, something else would have popped up.
I think the only places that call it social prescribing are actually at the commissioning level, because that's where, if the money is attached to social prescribing, they commission it as social prescribing, and then it gets personalised in terms of what people call it. Last thought, Olivia, just come over to you.
Yeah, sorry, I was just trying to lower hand and unmute at the same time. Catherine, lovely presentation, thank you, and for pulling it together at the last minute. You couldn't tell at all. It's lovely. I was wondering whether you could say a bit more about this point on kind of standardized evaluation tools, and whether in certain cases whether they're appropriate. Do you think there are alternatives to WebWebs, for example, or say a bit more as well about the kind of bespoke tools and the challenges of using something like that?
Yeah, so there are various validated tools, which are used in research, but the reason they might not be really applicable to every social prescribing project is that different services have different aims. So if you want to do something that doesn't match up exactly with this tool, then it's not going to be exactly the right tool to use. And also some tools can be quite long, or there might be some questions in it that are inappropriate. So for instance, in SwimWebs, there's a question about looking forward to the future, and people have found that's really difficult to ask people who've got a terminal illness or a life-limiting illness. So it's not always appropriate. Some are also very, very, actually not very detailed and quite short and quite general. So they're not picking up the nuances of changes. But they're available, they're validated, so they would give what would appear to be a valid result. On the other hand, if you as a social prescribing agency develop a tool based on either what you want the service to do, or sometimes a personalized tool where you're asking people to set their own, what they want to change and measuring that, then there are the problems of how do you know it's right if you're not a researcher, you're a link worker, or you're how do you know that it's capturing what you want to capture? But also, are people going to take it seriously? So especially the funders, they're going to take it seriously. So there's that worry. So there's that kind of tension there. Yeah.
It's another complicated question, isn't it? Because often what you measure is linked to what you want the service to achieve to begin with, isn't it? You sort of have to work one thing out and choose the tool accordingly. I've very cheekily put my call's a good tool. That's because I helped develop it, so I know it is well validated and pretty good. But I agree with you, and I think about items, particularly about the future or ONS4, where it says how worthwhile do you think your life is. That's not a great question to ask someone who's suffering with mental health and depression, and that's not comfortable for a consultation situation and trying to build up that relationship. But anyway, we've come to the end of our time, and it's been a small but perfectly formed group today, and some really good comments in the chat, and I think people have gone away with lots of information and understanding and resources and connections. So I'd just like to thank you, Catherine, and thank Sarah and Abby for their presentation, and look forward to seeing what happens next with the IEC. Any last word, Anthea? Handing over to you. No, she's shaking her head. Okay. Right. Well, we're going to finish recording, and take care, everyone. Thank you very much.